So within 10 seconds, after my countdown, we can start.
Your voice is not very clear. Within 10 seconds, I can able to hear, but it's not very clear.
So we are just going online, sir. He wanted to say. Next 2 seconds. Yes, Mr. Q.
Yes, sir. After my countdown, we can start. Give me just 10 seconds. So it's 3, 2, 1. Over to you, Dr. Amarjit, sir.
Yeah. So good evening, ladies and gentlemen, esteemed colleague and distinguished guest. This is Dr. Amarjit Singh, part of Lupin Medical Team. It is with great pleasure and enthusiasm that I extend a heartfelt welcome to each of you today as we gather to yet another enlightening session of IBEX webinar series. IBEX initiated with noble objective of sharing the latest and most compelling updates in the field of IBD and IBS, serves as a beacon of gastroenterologists, hepatologists, and consulting physicians worldwide. Our mission is to provide a platform where experts can share their wealth of knowledge, contributing to the continuous growth and development of our medical community. Today's webinar holds particular significance as we have privilege of hosting an eminent speaker, Dr. Arun, who will delve into the crucial topic of role of mesalamine in inflammatory bowel disease. So, few words about Sir. It's impossible to gather all the information about Sir within one slide. However, we have tried to collect all the important informations about Sir. Sir is associated as Assistant Professor in the Department of Digestive Health and Disease, Kilpauk Medical College, Chennai. Sir is also associated as Consultant Gastroenterologist in Apollo Hospital, Chennai. Sir was earlier associated as Assistant Professor in the Department of Hepatology, RGGH, Madras Medical College, Chennai. Sir has membership of several societies, including Indian Society of Gastroenterology, European Society of Gastroenterology, American Society of Gastroenterology, and Society of Gastrointestinal Endoscopy of India. Sir is very interested in research activities. Few of important research activity includes a study of clinical profile of patients with ulcerative colitis and association of neutrophil lymphocyte ratio with disease severity, assessment of liver function and its correlation with inflammatory markers and severity of disease during COVID-19 second wave in tertiary care center. One experience on his own center, that is cardiovascular abnormalities in liver cirrhosis. As a researcher, Sir has interest in the role of plasmapheresis in liver transplant recipients, immunosuppression in liver transplant, and among several achievements of Dr. Arun, that includes few of them: endoscopic ultrasound, pancreatic endotherapy, third space endoscopy, and 2 months of fellowship in US SGPGI. So, without further ado, let us welcome Dr. Arun once again. So, Dr. Arun, the virtual stage is yours, sir. Now, please welcome. Yes, sir.
Thank you, Dr. Amarjit, for your wonderful introduction, and thank you, Team Lupin, who gave me an opportunity to be here in this wonderful evening to discuss about one of the most common and worst entity in which we are facing nowadays. Initially, this condition tends to happen more in the westernized population. Now, even in Indian scenario, this inflammatory bowel disease tends to be one of the most common clinical scenario we have been frequently encountering. So, with this brief introduction, I'll be talking on with my slides and just uploading that. Nothing much to disclose. To be talking to talk about inflammatory bowel disease. So, what do you mean by inflammatory bowel disease? As you all well know about that, in which any inflammatory pathology, in case if it's going to sit in your bowel, so there are multiple presentations for you to land up with evidence of inflammatory bowel disease. There are multiple precipitating factors, triggers, and all those things will be there. My intention before we are going to wind up this session, you should know something in inflammatory bowel disease, how to tackle the clinical presentation, how are you going to recognize a patient with this kind of events, what are the various types, what are the various clinical presentation, basic investigations protocol, in case if you are going to start your management, how are you going to assess? As I previously discussed, inflammatory bowel disease nowadays becomes more common in Indian scenario too, and within a span of 1 month, I have come across more than 10 to 15 patients of inflammatory bowel disease. Why I would like to say this scenario, you need to be very cautious in recognizing the clinical presentation as early as possible. There are two major entities. One is ulcerative colitis and your Crohn's, which we all knew about all those stuffs, right from a basic MBS till your specialty and all those steps. But how are you going to recognize the presentation? How are you going to investigate the patient? And how are you going to tackle? And how are you going to recognize the complications based upon the event per se or based upon your treatment per se? And how are you going to manage the complications? This is what such a big area, and all of 30 to 40 minutes of my upcoming journey won't be suffice to talk on all those things. But my interest to talk on this area briefly before we are going to wind up this session. So as we all know that that's the chronic and debilitating inflammatory illness of your GI tract, as I discussed, mainly to entirety by your UC as well as Crohn's. And your pathophysiology will be a complex. As of now, there is no single pathophysiologic triggering factor being strictly identified. It's based upon your genetic vulnerability, your immunological complex based dysregulation, your environmental factors, your gut dysbiosis, so many other things. Your list of cascade is being triggered as one of the pathophysiological factors which is being involved in this inflammatory bowel disease. During the past few decades, significant advancements been made in the diagnosis and treatment of your IBD. The standard of treatment for your UC as well as your Crohn's has been entirely changed based upon your eco guidelines and other statement based upon your variant. And this is how Samuel Wells, what's been mentioned about, he coined the term ulcerative colitis in 1859. He described this in an autopsy patient who died with several months of diarrhea. This woman succumbed to Crohn's, who recognizes a separate entirety after around 70 years later. And why I would like to point out this is a common global health concern nowadays. 0.3 to 1% of the population being involved in this, and data set from 2019, what they mentioned that over 3 decades has been continuously progressing. The number of people living with IBD from 3.3 million to 4.9 million being surged, and Indian scenario to 2.7 lakhs, which has been increased from 1.3 from 1990, and this 2.7 being the current scenario which is happening in India. And we need to have a safe strategy to maintain a definitive diagnosis of your inflammatory bowel disease in 5.4% of the population. And apart from that, in out of 30, so what's been mentioned is that, so when compared to your rural as well as your urban India, your results from your colonoscopic evaluation of more than 30,000 symptomatic patients, in which we can able to identify CD Crohn's around 3.2, which is more common than UC, around 2.2. So CDs to UC ratio 1.4 to 1. Why I would like to point out this picture, because right from pediatric age group to early, late, around 60 to 70 years older population, almost the geriatric range, it can affect any age group. There's a bimodal range of presentation, various classifications, clinical assessment, severity, three major entities. Always recognize the patient by clinical, your lab parameters, your inflammatory cascade of markers, and apart from that, your histological improvement. Various scoring systems being there to categorize your UCES, ulcerative colitis index, your Crohn's disease index, and endoscopic severity index. So many indices are there for your clinical presentation, as well as for your lab recognition, as well as for your histological assessment. Why it's very important? Because based upon that, you need to target the patient with various regimens, which is being widely available and being tried. Since this patient will be chronically ill, debilitating pattern of illness, and most of the time the patient will be having functional disability too. The patient will be psychologically more complex phenomena. Sometimes the patient may go for surgical intervention at the point of time. It will be very difficult so to lead a normal life in this society and community. So this is more psychological interventions too supposed to be done in a regularized manner in order to recognize this presentation and to tackle assessing the patient as a whole with various coexisting presentation and coexisting complications. Everything to be recognized if you want to tackle this inflammatory bowel disease. And we need to categorize, we need to differentiate whether you're going to label the patient as UC or Crohn's. Even for the best of gastroenterologists, still a definitive conclusion is most of the time will be a diagnostic dilemma, because if you're going to look into the differentiating factors for your UC and Crohn's, even though some of the conditions of Crohn's will be mimicking your ulcerative colitis. So always you need to assess the patient as a whole, clinical history, semiology of presentation, complications in which the patient is developing, lab picture, serological markers, so many other things are there. Briefly, I'm here to brush up all those areas. So clinical presentation of your inflammatory bowel disease vary greatly, but frequent symptoms will be your characteristic pain, which is based upon your various pain pathways, is going to get included. Apart from that, your GI symptom of diarrhea or GI bleed. In case the patient is going to present with UC, there is high evidence of rectal involvement at the point of juncture. The patient may have rectal bleed along with tenesmus, and other characteristic presentation may be reported. Any events, usually weight loss, exhaustion, fever, and multiple non-GA presentation, extra GA manifestation, starting from your head to foot. For example, in your eyes, in your oral cavity, in your nails, in your hands, from in your liver, other systems of involvement in your dermatological areas. So many in your arthritis, in your ortho as well as rheumatological criteria. So many arthritic findings will be there when you're going to look at the extra GA manifestations when you're going to tackle this kind of presentation. But my intention, first pointer, recognize the event, characteristic will be the pain, predominantly will be in the left lower quadrant in case of suspicion of your IBD of UC, and will be the predominantly in your periumbilical pattern in case you're going to suspect your Crohn's, and your diarrheal pattern, rectal bleed, your diarrhea, weight loss, and a diarrhea predisposing predominantly of right side involvement of your colon, which is more common in case of Crohn's, and weight loss, exhaustion, fever, anemia, clinical presentation, and so on and so on. And briefly about, as I discussed, Crohn's is one of the most difficult entirety to recognize as well as to tackle, because right from your oral cavity till your anal canal, it can involve any region from your oral cavity to anal canal. It can involve your esophagus, stomach, as well as the common area of small bowel. One of the difficult challenges, it can also involve your large bowel, and these are all the areas you need to answer. So if it's going to affect your small bowel, as you're well aware, the length of small bowel will be around 6 meters so far. It's very difficult to recognize the presentation in the initial way. There are so many modalities to diagnose of complications which is going to happen in your small bowel pathology. You can do your capsule, you can do your enteroscopy or enterography, there's a CT or MR. So what you're going to do, how are you going to recognize the presentation? That's what the most important eventually bring up this kind of conclusion when you are going to tackle this inflammatory bowel disease. And Crohn's disease, as I discussed, any region of your GI pathology, And apart from that, the terminal ileum and colon will be more commonly involved areas. But I will see one thing. Sometimes you may get only mild ileitis that might be idiopathic, in which you couldn't able to identify any etiological factors. If you're going to do the lab workup and other parameters, some minimal ulcerated changes will be there, but doesn't mean the patient's having evidence of your. So always you need to think differential diagnosis when you're going to tackle this kind of presentation. And next to that will be your transmural inflammation. That's a characteristic pathology for your CD, which results in your stricturizing, fistulizing abscess formation. So that's what is called a psychiatric changes will be there, and the patient will be having various classification of Vienna and other things, and therefore your Crohn's and others supposed to be your fistulizing and stricturizing, your penetrating lesions. That's why if you're going to develop a fissure or fistula nano, we need to be very cautious to touch in the patient in the background a complex fistula as per a good South criteria. If you're going to look into that, you need to be very cautious when you're going to do a surgical intervention, because that might be a catastrophe, that might be the precipitating factor for the problem to get worsened. So before doing a surgical intervention, we need to tackle with the medications, sometimes your monoclonals, your TNF and other things, and you need to be very cautious when you're going to recognize this kind of presentation. Apart from that, multiple level of extra GA manifestations starting from your oral cavity, your joints, as discussed, your rashes, as your changes in your iritis, your uveitis, multiple other pathology which is going to develop in your eyes, and you need to look for your UC, for example, predominantly in your large bowel. Usual length will be around 1.5 inches, as you have been well aware, but the predominant lesion will be in your large bowel, and the rectum will be predominantly involved, and the lesions tends to be your continuous pattern, and mainly the mucosal layer will be involved when compared to your CD, which is being a transmural level of inflammation. And chin smells urgency because of your rectum. Rectum is the area in which is going to have a huge load of stools, and that's the area which is going to get accompanied because of your lesion. Once a erythema, based upon your endoscopic classification, your erythematous lesion, your friable mucosa, blistering changes, polyposis, pseudopolyposis are the common complications. So all this presentation will be there when you're going to think in terms of your ulcerative colitis, bloody diarrhea, characteristic presentation. The patient may be anemic based upon your criteria, what is called as true lung open veins. You need to categorize the patient by mild to moderate and severe presentation based upon your lab criteria, your albumin levels, your fever, tachycardia, your coexisting, the severity of events of your bloody diarrhea, your anemic parameters, all those pointers to be taken into account when you are going to tackle a patient with inflammatory bowel disease. That is why it is one of the challenging issues, even for the best of consultants, even for the best of center, even for the best of country. Why I would like to point out always this diagnostic dilemma, the issue is still happening, and there are so many updates been happening in this field, and we need to update, even as a consultant, we need to update our knowledge in this area when you're going to tackle this presentation, because new molecule innovation, the representation, and apart from that, whether the patient is responding or not. If no response, what's the next line of therapy? Whether the patient deserves medical management continuous, if you're going to continue, how long you're going to continue. So many questions. Definitely it's going to get happen, and assessing the complications as what have we discussed, and assessing the extra GA manifestations is also very important. Basic outline about your pathophysiology cascade which is happening in your IBD. It's mainly, as we discussed, based upon your environmental. Any usual chronic pathology will be in this four area, like your autoimmune conditions, your environmental predisposition and genetic, your immune, as well as your gut microbiome. That is why nowadays gut microbiota has been considered as a separate system which is going to tackle not only in your GI, for multi other organs to be considered. This multifaceted pathophysiology, what is going to happen, and this genetic factor, so many susceptible loci being identified. The basic one, your NOD2 mutation, your ATG, as well as your interleukins 23. These are all the dysregulated cell responses is going to happen. Not much of theoretical aspect, but you should remember that node aggregation path and all those things will be a cascade of events to predispose to this kind of presentation. And environmental variability based upon your genetic factors as well as your development, all those things could be a predisposing, but still no single conceptual method to prove these things are being there or not. These are all the hypothetical events being happening, but we need more and more papers to support these evidence which is happening or not. You're smoking, your diet changes, your changes in your gut microbiota, your firmicutes, your bacteroids, all those alteration, your prasnids, all those alteration, and your virus, which is predisposing to any exposure, to any acute viral exposures. All these things could be a predisposing worsening of events to have a remission or relapse of worsening of events at that point of time. And the gut microbiota, as I discussed, the alteration in your normal gut microbiota, if the eubiosis, if it is not going to be the symbiosis, if it is not going to get maintained, and the dysbiosis is going to get check on with that, at that point of juncture, there is high possibility for you to land up with your inflammatory bowel disease, and this changes will result in pro-inflammatory cascade activation. Your inflammatory pathway is going to get augmented. And this is what the T regulatory cells and your B regulatory cells, which is being the main pathway, is going to get involved. As I discussed, these cells get weakened off, which is going to cause a prolonged inflammatory changes and tissue damage. And the intestinal barrier, which is going to get altered, the changes, the integrity, if it is going to get lost, and your mucous layer function, if it is not going to be there, that might be the precipitating factor for your IBD. And these are all the theoretical areas, like your you need to analyze this. So briefly, if you want to look into this, the triggering event, what are the various triggers? Gene, environment, intestinal flora, any specific agent or virological trigger, autoimmune focus, all those things. What's going to happen if it is going to trigger your immune system, which is based upon your T regulatory and B regulatory cells, and your non-immune area like your epithelial mesenchymal cells and endothelial cell activation. What's going to happen? The autoantibodies are going to generate, which is going to augment your intestinal inflammation, your various growth factors is going to release, and the inflammatory markers like your eicosanoids, your arachidonic acids, and all those things, your proteolytic enzyme, your reactive oxygenation pathway, and your nano as well as your neuropeptides, if it's going to get involved. There are so many other cascades to think in terms of this intestinal inflammation to get set on. But what I would like to point out, so the basic thing, the environmental trigger, the genetic and microflora, as well as the specific etiological agent, and your immune as well as your non-immune activation, which is predisposing to multiple level of cascades or pathway to predispose to your intestinal inflammation to get activated. And what is the basic diagnosis? So this is what the basic pathophysiology. How are you going to diagnose this presentation? So diagnosing a patient with IBD, the foremost one is your clinical assessment. Young female or older generation, young male or older generation, at that point, suddenly the pediatric or other age group, they are having a certain worsening of events with extra GA and non-GA manifestations. Always you need to look for the clinical presentation, which call characteristic events like pain, GI symptoms, diarrhea, and other things. Sometimes the patient may present with isolated jaundice too. At that point of juncture, you can able to identify a coexisting other presentation. So why I would like to point out, so the huge list of battery of investigations that there, basic blood parameters to identify your source of anemia, the severity of based upon your ESR, CRP, your cat protection levels based upon it's going to be less than 40 or more than 40 at the point of juncture. And so many other new markers like your lactoferrin, other things are there. Apart from your radiological parameters, your basic investigations like your upper GI endoscopy, when you're going to suspect evidence of Crohn's, which is going to be there, and your lower GI endoscopy, mainly your colonoscopy to identify the level of lesions. You're assessing the endoscopic severity. Based upon that, for mild to moderate and severe indices being assessed, and all those punctures, then lab parameters. Once the patient is developing complications like your radiological imaging, if the patient is having strictures, if the patient is having evidence of obstruction, if the patient is having evidence of other complications, in case your MR for your fistulizing lesion, your stricturizing lesion, and sometimes in case of the small bowel involvement, your enterography as well as enteroscopy, as I discussed, your ASCA and ANCA could be considered serological markers, anti-saccharomyces and anti-neutrophil, cytoplasmic. All those things you can consider as a marker for your CD as well as UC, but there is no one single proven indicator to consider this as a specific puncture to prove this entirety, because it's a conglomeration of multiple things. You need to assess the patient as a whole, look the basic investigations, and recognize the patient with basic first level of endoscopic evaluation. If you have suspicion of any ileal involvement at that point of junction, if you want to assess the extent of lesion, you can progress the patient with enterography, scopy, and other support, and recognize whether the patient is having evidence of CD or UC. And endoscopy always is very important. So start from your baseline, look for evidence of low albumin, hypoalbuminemia, your ESR, CRP, other markers, inflammatory cascades. All those things is important as a basic picture before you're going to diagnose. And what are the investigations? When you're going to start a medication, for example, first line of medicine, when you're going to think steroids, always you need to be conscious before starting. You need to rule out any coexisting other immunosuppressive cascade in the infective focus. Always you need to look for evidence of varicella zoster, pneumococcal, your flu viruses, your tuberculosis, which is one of the most common triggering factors. I have seen multiple patients who started on steroids, suddenly the patient developed miliary tuberculosis. We have lost a patient, young female, just 20 years completed, died because of CD, and within a span of initiation of steroid, the patient developed a fulminant miliary tuberculosis in the background, and the patient needs to have multi-organ system, multi-organ dysfunction at that point of time. The patient deserves pancreatectomy, but even then, we couldn't able to revive the patient. The patient succumbed at a young age. So I would like to point out, so all these pointers is important to recognize the patient as a whole in order to diagnose. That's why tackling inflammatory bowel disease is a lifelong learning process, even for the best of consultants in India. So what are you supposed to do? As I discussed, this is a huge list of investigations starting from your endoscopy, your enteroscopy, molecular arrays nowadays being used, and your newer innovations like your magnification endoscopy, confocal microscopy, in order to differentiate yourself from your neoplastic changes. There might be, once a patient is having evidence of colorectal involvement like your UC, which is going to have a severe involvement at that point, over a period of time, there is high possibility for the patient to land up with evidence of neoplastic changes, sort of polypid for a colorectal malignant pathology. So you need to be cautious to have a regional surveillance to this kind of patient. There are separate charts to assess how frequently, how are you going to monitor based upon the region of involvement. These are all the things can aid in your diagnosis for your inflammatory bowel disease. But clinically, the diagnostic criteria, as I told you, based upon for basically about UC, your rectal involvement, urgency, and tenesmus and rectal bleed, endoscopic identification of cascade of inflammation, predominantly in the large bowel. Histopathology will be your crypt distortion along with your cryptitis and crypt abscess. The predominant area will be your submucosal and the mucosal layer of involvement rather than your transmural platform involvement, which is being predominantly considered in case of Crohn's. And apart from that, in Crohn's, it can affect any area. Diarrhea will be a characteristic event. Pain abdomen will be a characteristic event, but rectal bleed can happen, but it's slightly uncommon when you're going to think in terms of your UC and transmural inflammation. So always difficult to diagnose and tackle. And granulomatous changes is there when you're going to look into your histological assessment. That's what is very important when you're going to diagnose. And apart from that, the basic classification is based upon your Montreal's, your Vienna Society, and all those things. So, for example, in case of Crohn's, you need to see the area of involvement. Location, predominantly right-sided, colon, or left-sided, or in the background of ileal involvement or small bowel. The location, behavior, cicatrizing, stricturizing, penetrating. The age, what is the age criteria? It's the pediatric or middle age or older population. So all these things based upon, you need to categorize the patient from your lesion location, age, as well as your progression. And in your UC, whether it is pancolitis, now another terminology, extensive colitis, which has been predominantly involving in your right side of the colon too, and your predominant left side of colitis and proctitis, only in case if it is going to involve your rectum. Because based upon that, you're going to tackle your management and complications. You list out there. Mainly, we need to look for GI complications as well as your extra GI complications. As I discussed, some rare possibilities based upon your characteristic. For example, in the case of you see the common characteristic complications will be arterial disturbance. Once it's going to get disturbed, there is a possibility for the patient to land up with evidence of the toxic megacolon, if the transverse colon diameter, if it is going to be more than 5.5, at the point of junction, you need to be very cautious, and that kind of patient deserves early intervention as early as possible to overcome the clinical presentation. And extra GI manifestations, so many times we have been discussing right from your basic MBBS knowledge, what we are going to do that hepatobiliary, arthritic, rheumatological, like your pyoderma, weeds, your acanthosis, so many other things are there, and you need to be very cautious when you're going to recognize, because to whom you're going to initiate the molecule based upon your drugs, or sometimes your fixed drug interaction, other things. All these things is there to tackle the presentation. Inflammatory bowel disease, you may develop the problem because of the disease per se, or because of the individuality of the patient, or because of the treatment protocol what we are going to initiate. So all these three entities to be assessed before you're going to tackle such presentation. And treatment goals, we need to improve a sustained remission, maintain a remission. First, we need to induce a remission, and we need to maintain the remission, and we need to prevent the complications. We need to treat the complication, mucosal healing, endoscopic severity has to come down, and quality of life, the weight gain, the diarrhea, liver, the bloody diarrhea, stools, everything, your inflammatory cascade has to improve. That's the main treatment goals for you. And approximately 20 to 30% of UC and about half of CD may require surgery at the initial point, in case if you're not going to diagnose this presentation in the initial way. And in order to remove muscle abscess, you need to tackle as early as possible to prevent the further complications. So pharmacological treatments, common line of treatments, you list is there commonly. That's what the area have been initiated today to discuss about the basic molecule for your UC as well as a CD, which you're going to tackle with your mesalamine preparation. Your list of preparations is there. Your aminosalicylates. Next to that, your corticosteroids, starting from your prednisolone, which is very well known, and it's causing huge number of complications over a duration of time, starting to 40 to 60 milligrams. And you can titrate the patient slowly over a dose of 5 milligrams graph. If you're going to titrate, and more now, JAK inhibitors, yotofacitinib is having a very good role for mild to moderate severity. At that point of junction, nowadays you are going to consider your biologics. For example, your infliximab, your along with your adalimumab, you can even consider your ustekinumab and other molecules. And nowadays we have been using some patient other molecules to be considered, and azothioprine, methotrexate, based upon your other clinical representation to be enlisted in your clinical approach or protocols. And there are a list of limitations of these molecules, starting from your steroids, mainly because of your sugar fluxing levels of your sugars. Your glycemic index may get vary, and you may have bony complications, you may have fluid retention, you may have disfigurement, and you may have wound healing, which is going to be impaired. Your immune response is going to be poor, myopathy, so many other complications. Your adrenal axis, hypothalamic pituitary axis may get suppressed. So you need to be very cautious when you're going to recognize this presentation. And apart from that, your JAK inhibitors, infection risk will be high. For example, you're going to tackle yotofacitinib, but there are papers to prove that we can use safely after giving your basic vaccination and other protocols to be initiated. And at that point, the patient's creatinine levels, your LDL, and other things to be monitored, your biologics and common things, your list of infections are there. You need to address the infection before that, giving a patient biologics, and the patient may have evidence of secondary malignancy. Some patient, your non-dermatological manifestations, your skin malignancies. But so many other things are there when you're going to use your biologics too. And vedolizumab is being available in the market to consider. Even my experience, for 2 to 3 patients being tried. If the patient is not going to respond with adalimumab and other molecules, when you're going for a severe colitis at that kind of presentation. So the basic one, always 5-ASA based therapy, mesalamine, start from 2.4 to 4.8 grams per day. When you're going to think, so what is the protocol? What's the role? So it's still the first line of therapy, effective in mild to moderate UC, and can be administered in many formulations. That are pH dependent, diffusion dependent, your chronic flora dependent, as well as your topical regimen based upon the area. That's what assessing the patient as a whole, where the area you're going to target, all those pointers is very important when you're going to manage a patient with this inflammatory bowel disease cascade. And apart from that, so what is the main mechanism of action is? Just a minute. So the main mechanism of action is by your inhibition, your induction, and all those things. So what is going to happen? The main thing is H to be determined, your anti-inflammatory cascade of action of your mesalazine, your immunosuppressive properties, your free radical scavenging and antioxidant activity. Apart from that, the inhibition of your synthesis of your prostaglandins. So what's going to happen? The prostaglandin synthesis is going to get inhibited by your anti-inflammatory events, your inhibition of addition of macrophages and neutrophils, and immunosuppressive, for example, your impairment of the white cell addition as well as your function during acute inflammation, and your free radical scavenging and antioxidant activity, and limited tissue damage associated with inflammatory bowel disease. So these are all the things you need to be very cautious when you're going to. I mean, this is the area in which it's going to have the predominant mechanism of action is going to get involved. So your inhibition as well as your induction part, you need to remember that your interleukins, chain of your arachidonic and your leukocyte chemotaxis, your prostaglandins, your induction of your apoptosis activation, your expression of your PPARs, and this is what the molecule for your mesalazine to be considered. And and regarding the pharmacokinetics, briefly, you should remember the half-life will be around 7 hours, and the elimination will be predominantly 72% will not be absorbed and eliminated in the feces and via oral administration. So what's going to happen? And the primary compound will be predominantly excreted in your urine. So clinical efficacy, if you're going to look into the paper, once daily dosing versus conventional dosage schedule of your mesalamine and relapse of your quiescent UC. So what is going to happen? So first thing, you need to look into your randomized trials. So what is going to happen? So what is the thing which is going to support? So adults, when you're going to use your once daily dosage, or as it's a conventional dosage schedule of your mesalamine and relapse of your UC, what's going to think in terms? So the ideal thing will be you need to maintain a target, at least DOT should be going more than 4.8, so 2.4 milligrams twice daily, or nowadays 2.4 grams twice daily. So all those things can be considered, and once daily versus conventional dosage schedule we can consider, and minimum duration should be for 6 months of period. And apart from that, so this is what the same thing in which the risk of relapse with once daily dosing compared with your conventional dosing schedule, what's mentioned in that. So once daily and conventional doses, this is what the various graphs being represented. The conventional, nothing much of major changes, but usually splitting up the dose, 2 regimens will be a conventional more than going for once daily regimen. At that point, once daily dosing is as effective as conventional, but it's very difficult to give. So always the formulations like your 1.2 or 2 grams when you're going to use, you're always going for a split up of 2 doses regimen rather than giving 3 doses or 4 doses regimen. It's not much of it's more much of difficulty when you're going to use it. And once daily oral mesalamine compared to your conventional dosing, this is what the same thing, but you need a proper analysis for that. Once daily mesalamine appears to be as effective and safe as conventional dosing for both the treatment of mild to moderate UC and not to maintain a remission of your quiescent UC. And apart from that, so once daily mesalamine has a favorable safety profile for the maintenance of remission for up to 2 years in patients with UC. And this is what the same thing, once daily was well tolerated for long-term maintenance of UC with a low risk of UC-related adverse events that are generally indicated of relapse. The favorable long-term safety profile and convenient dosing regimen of your mesalamine support its administration for the long-term maintenance of your UC remission. So guidelines based upon, list of trials are there, but Crohn's and Colitis Foundation, the strike organization, what they are going to treat to target therapy, we are going to consider. So that's what they say. The 5-ASA containing formulations are effective for induction of remission patients with mild to moderate UC, and the extent and the first line of indications always to be considered. And Crohn's and Colitis Foundation. So what the first line of treatment for always mesalamine, the second line, you list are there that we'll be discussing. So as I discussed, one is based upon pH, pH dependent, your time dependent, your diffusion dependent, that's what the time, and your topical, your bond. So all those things, for example, your mesalamine, oxalazine, balsalazine, sulfasalazine components, you list of compounds are there, and there are various preparation, oral preparation, your enemas, your topical regimens, and all those things. Suppose if the predominant lesion would be in the lower or left side of colon, you can consider the patient with your topical regimens too, and based upon your various protocols, what you're going to initiate. So you need to manage a patient with inflammatory bowel disease. There are a huge list of formulations are there when you're going to consider. And this HHS access, what we mentioned, in that your AG association maintained the guidelines on the management of mild to moderate UC, and this is what they've been pointed out. The mainstay for therapy is a 5ASA, to be considered always in the mention of managing a patient with your inflammatory bowel disease, and your Polish Society of Gastro, what they mentioned in that. So the basic thing, orally or actually for mild to moderate exacerbations, you can consider, and your types as I discussed, your pH dependent, your time dependent, your multimatrix system, all those things, and your selection of formulation. This is what are you going to select. For example, your topical or oral. So always orally given means the local release will be predominantly the right side. Enema means will be predominantly reaching the splenic flexure from your lower GI, and suppository means it will be predominantly in your rectum as well as 15 centimeters from your anal verge, forms up to sigmoid colon. So these are all the areas in which you are going to tackle, and what you're going to present based upon the endoscopic assessment and severity. That's the area you're going to tackle your management. Dosages 2.4 to 4.8 grams per day. That's what for induction and maintenance. How long you're going to give? Whether monotherapy alone, that's one of the common questions. No, always monotherapy alone not to be considered when you're going to manage a patient with inflammatory bowel disease. That's very, very important. You need to give a combination therapy with steroids. If it is non-responding, you need to go with other line of molecules. Start the patient with azathioprine when the patient is on tapering dose of steroid. At that point of time, even if the azathioprine, if the response, if the remission is not maintained, then you need to consider the patient with your biologicals, a JAK and other inhibitors. So all those things you need to be very cautious when you're going to tackle. And before that, as I discussed, assessing the infection, assessing the clinical regimen, assessing the patient as a whole is very important to tackle this kind of events. And initial choice, as I discussed, your nowadays your MMX-based mesalazine therapy being well available in the market, and apart from that, your main thing of mesalazine when you're going to consider as to look for the patient adherence, and by which area you're going to get target, and look for the clinical response based upon your lab parameters like your CRP, albumin, your calprotectin levels, your colonoscopy assessment, and you need to reassess the patient whether the patient is worsening or the patient is responding. You need to see. And usually the disease distribution will be in extensive colitis. You can use either pH dependent formulation or time dependent formulation. In ileal, it will be predominantly a time dependent formulations. These are all the things you can consider when you're going to manage a patient with inflammatory bowel disease. And to discuss some case scenario briefly about that, what we have done recently, which was happened 1 month before, what we had tried for a patient, it's a young female who had pain abdomen, diffuse in nature, just 23 years completed, and dull and colicky. She presented to us in the background of increased stool output, more than 10 to 15 episodes per day, and blood mucus discharge is obviously being rectum. Tenesmus is characteristic, appeared, as you all know, this picture more in favor of UC, and no major joint pain, no major GM manifestations, and this patient, no major evidence of comorbids like your hypertension, diabetes, your tuberculosis, your thyroid, any surgical events, and social drinking in young female was there, but non-smoker. But apart from that, no major GM malignancy or the pathology. Apart from the patient clinically looks to be febrile when we are examining, and the bilge is thin and paralysis is there, and no major cyanosis or icterus, no major clubbing or lymphadenopathy. Vitals are okay, and the patient's cardiac status is fine, respiratory status are fine, mild diffuse tenderness in the abdomen, but mild, not much. No major organomegaly been reported. When we are going to investigate this patient, she tends to be anemic, and the hemoglobin goes in the range of 8. The liver values, not much of alteration. Albumin is well maintaining, and renal function is well preserved. Viral markers are negative, your BC and HIV, and X-ray and abdomen X-ray, everything tends to be fine. Stool examination appears to be fine. But even though it's not a strict recommendation, since the patient had fever, at that point, in initial workup protocol, we have been done that. Apart from day one, we have initiated with the basic antibiotic-based regimen, and since we already knew that the patient had evidence of UC, we need to be very cautious when you're going to use your steroids. We need to see whether the patient is having relapse and other things. And apart from that, we need to start the patient with steroids with your azathioprine and your mesalamine. You're going to initiate always mesalamine to be considered, and you need to assess the stool frequency based upon your criteria of your true love and myths statement, and what you are going to see if it is not going to respond on day 6, which means you need to say tackle the presentation like your ulcerative colitis. I mean, severe indices. So acute severe colitis might be there, even though if the patient is not responding, then you need to go with injectable therapies of your steroids like hydrochloride 100 milligrams 6 hourly, assess the patient with stool frequency, and even after that, if it is going to persist, the frequency, if it is going to be more than 15 times, and you're going to withhold the steroids if you are not going to respond within 2 to 3 days of therapy, at that point of time, you need to see the platelet count is well mentioning, your albumin is still mentioning, and your hemoglobin is still preserving in the lower range, but not too low. And X-ray is okay. And apart from that, day 12, the patient becomes afebrile, stool frequency 5 to 6 times still maintaining, and your colonoscopy, the Mayo severity indices based upon 2, and we are checking always biopsy to rule out any coexisting any antibiotic or prostatitis difficile colitis or CMV colitis, all those things. And we need to think in terms of the patient is going to work up for any biological support at this point, because the stool even is still persisting. And after performing the basic workup, that's what I mean discuss, you need to look for the vaccination protocols. You need to take care of infections like your tuberculosis, your CMV, your EBV, your varicella zoster, your tuberculosis, very common scenario. All those things you need to be very cautious. And before considering that, we can consider this patient with your 5 milligrams per kg. And at the point of your infliximab, we have been started the patient on infliximab with 5 mg per kg was initiated. At the second dose, the patient developed a rash. And again, what we have done, we have been switching over the patient, and adalimumab was started. So the drug was not effective in the initial phase like your infliximab. So we are switching over to adalimumab, and we have given a sole dose of 160 milligrams in the initial phase, followed by 80 milligrams of maintenance. We have been done. And serially, we have been responding. So during this phase, why I would like to point out this picture, during this phase of treatment, we are continuing the patient with mesalamine. So mesalamine is always a support. So this is what the initial picture in the initial phase before you're going to see. This is what, so the vascular pattern has been completely distorted, that mucosa has been completely under erythematous blistering mucosa. We can able to identify pseudopolypoid changes in these areas, multiple is scattered almost. And after 6 months of therapy, so we can able to see there is some response being there. The polypoidal changes has improved, but still the lesion is still persisting. But over a duration of time, at around 2 years of therapy, so that we can able to identify the response is going to well maintain with the mesalazine monoclonal. That's what you need to try to. So this is what the response over a period of 2 years we have been acquiring with this kind of patient. So that's what, before concluding, I would like to point out, it's a chronic entity. You need to recognize the patient as a whole. Always recognize the clinical presentation and see the history in favor of CB, UC or CD. Not all bleeders are inflammatory bowel disease, so you need to be cautious to label the patient as inflammatory bowel disease. Refer the patient promptly to the gastroenterologist to approach the patient significantly in a primary physician level. So you need to be cautious not to miss out any basic complications like any abdominal worsening or megacolon, other complications like presentation, developmental disturbances if the patient is having evidence of anemia, cardiac compensation, shock, and other presentation. That's the basic thing you should not forget when you're going to manage the primary level. At that point of juncture, assessing the patient and look for the triggering factors. See whether the patient, what line of clinical representation, treat the complications like anemia, look for the basic markers, your inflammatory cascade, and subdivide the patient with your acute colitis or the chronicity which is going to be there, or relapse or worsening, all those things, and then initiate the molecule stepwise escalation protocol regimen to be initiated, starting from your 5-ASA, mesalamine, and you need to go with your steroids or your monoclonals or your JAK or azathioprine, all those things, immunologic. So all those molecules, when you're going to give as per the by stepping up of ladder. So you need to be very cautious when you're going to give this management and look for coexisting infections is there or not, and always take a biopsy for your CMV, Clostridium difficile, all those things. Apart from that, recognizing the complications is very important, like your megacolon, your malignant changeovers, surgical intervention. Sometimes the patient may deserve, always you may need to go for total colectomy at some point of juncture, some patients, if you're not going to tackle the presentation rightly. Recently also in Apollo, we came across a patient diagnosed as active colitis, the patient not responding to multiple regimens, and the patient not much of knowledge, but now the patient is gone for multiple complications, be anemia, other thing, and they're taken over for the patient for surgical intervention, and more of the patient demands for surgical intervention. These are the things which is happening. So why I would like to point out, you need to be cautious when you're going to manage a patient with inflammatory bowel disease. With this, I'm happy to rest my presentation. Thanking you all for patient listening.
Thanks, sir, for your remarkable and wonderful presentation. And sir, you have covered almost all the points related with the management of IBD. So I think the listeners definitely satisfied with the presentation. And however, sir, just a few query we have received. Sir, what is the percentage of mortality associated with IBD according to your clinical experience, sir?
So, based upon the clinical experience, the percentage of mortality is definitely very, very low, but the morbidity will be very, very high. The percentage of mortality in our clinical experience will be less than 5%, because nowadays a huge list of molecules are there, but the problem is whether the patient is adhering to the therapy, whether the patient is strictly following that. That's a very, very important things we need to be, we need to look into that when you're going to manage. And the percentage of mortality, if the patient is strictly adhering, look for the coexisting other events, tackling the infections, intercurrent events, and all those things. If you're going to do, it will be definitely less than 5% when you're going to tackle. But the patient may deserve surgery intervention too at any point of time, that we need to be accepted. And mortality rate is very uncommon nowadays with this regimen, but mortality is still being established in many centers over a period of time. And sometimes fulminant septicemia, based upon your, even for the patient who is going for your various stomies, pouch, other things, the patient may go for dehydration, fluid replacement, shock, and other complications, multi-organ involvement. At that point of time, the patient may go for fulminant sepsis and other complications. So these kind of scenarios, in my personal experience, will be around 5 to 10, but not more than 10 for sure.
And sir, the patients who visit your clinic, sir, what is the ratio between ulcerative colitis and Crohn's disease, sir?
So what is the criteria to diagnose your ulcerative colitis and Crohn's means predominantly the age criteria, what you're going to tackle. In pediatric age group, Crohn's is very common rather than your UC. But the characteristic presentation of your UC, if you're going to well look at the characteristic bleed, the frank bleeding, abdominal pain, anemia. But in case of your CD, the characteristic presentation will be your right side chronic involvement, like your diarrhea, fever, weight loss. And all those pointers will be there. And anemia also will be a coexisting presentation. But your Crohn's is very difficult to tackle, because ulcerative colitis, if you can able to diagnose, there is strict protocol, but Crohn's very problematic because it can involve any area. Upper GI, we need to look into other findings. Small bowel, we need to look into more changes in case if the patient is landing up with the evidence of small bowel changes, cicatrizing, structurizing lesions and all, then we need to go for dilatation and eyeliner, the cost issues, the financial issues, all this burden will be very common. Huge demands will be there in Crohn's rather than in your UC, because Crohn's is involving every part of the colon, but your UC will be predominantly restricted to your large bowel. I'm not saying it will not be involving small bowel too. It's a backwash ileate is still happening, but we need to be cautious to recognize the presentation. But Crohn's is usually time consuming, chronic, more chronicity, cicatrizing, structurizing, and abscess, your fistulization, your fissures, and other surgical interventions. So many other complications will be reported in your Crohn's. And your UC easy to diagnose, and the tackling will be easy when compared to your Crohn's, and the Crohn's will be more complex scenario. You need to be very cautious when you're going to tackle that kind of presentation.
And sir, how long mesalamine you prescribe to your patient? Does it depends on the sign and symptoms?
Usually, the dose of mesalamine depends upon the severity of disease, but mesalamine alone usually will not be considered as a monotherapy for most of the patients. And in my personal experience, I never tried monotherapy with mesalamine alone. But mesalamine not only used for IBD, you should know the use list of armamentarium protocol. You can use for diverticulitis, you can use for pouchitis, so many other things you can use your mesalamine. It's not been a single stage molecule only for inflammatory bowel disease. But why I would like to point out, at least you need to use for a duration of 6 months when you're going to use. And we have been having trials for people. We have been using some patients for 2 years to your mesalamine based upon the response in which they are going to categorize.
So not prescribing as a monotherapy, does it cause that when patients visit to you, sir, they are in the complicated situation? So that's why
That's what we
combination
have
of
been. So that's
therapies.
what we have been saying. What is the complication you're going to see? Usually, there is no much of papers guidelines when you're going to look into eco position statement. Monotherapy for your inflammatory cascade it's not be much of representation. But mild proctitis you can find for monotherapy, but with your enema-like preparation. But even then, ideally depends upon the severity. You need to be cautious. Always monotherapy. It's not be much of recommendation when you having a proven evidence of inflammatory with markers slightly tends to be the higher side, calprotectin still in the worsening side. All these pointers you need to be cautious when you're going to look into your presentation.
So we are still waiting. If any query will come, definitely we will take it, sir. Just we will wait for 1-2 minutes more. So I think we don't have more queries because definitely, sir, your presentation was remarkable. So at last, just vote of thanks.
Sir, we have one
So,
query. Hello.
pardon, tell me, sir, tell me.
Yeah, sir, there is one query I have posted in the chat box. Just recently I have received.
Okay, just okay. So the query is, sir, how often you are using LMWH in patients presenting with bleeding, PR, and severe colitis?
Low molecular weight heparin, you need to be very cautious when you're going to use the patient with severe bleeding. Ideally, you need to stop the molecule, unless and otherwise if the patient is not having evidence of coexisting thromboembolic complications. But once a patient is having evidence of active bleeding, my experience with using LMWH is definitely low. We are not being considered for that kind of patients because always getting a fitness of cardiac status and all those things is important. But isolated active bleed, no response of your, you should be very cautious when you're going to use LMWH. Ideally, it's better to stop the treatment.
Yeah. So another query, sir, after starting mesalamine, when would introduce azathioprine and what
Azathioprine,
dose?
azathioprine you can introduce not after mesalamine when you're going to use steroids. Once the patient is going to use steroids, that's what the guidelines. See, every week you need to taper the patient with steroid. There are so many protocols and so many confusions is going to happen with your steroids. Some guidelines mention as 40 to 60 milligrams. Some patient will be overweight. We don't know what the dose to be initiated. So ideally to start with 40. But when you're going to start tapering, if you're going to start taper within 1 week, so for example, that's what the guidelines mentioned. Every week, 5 grams, 5 milligrams to be reduced. But what is going to happen over a span of time, within 8 weeks, the patient will be in 5 milligrams. I have seen multiple patients who have been tapering like that. So within a span of 8 weeks, the patient is not responding at all with your prednisolone and your moderate colitis, your moderate CD. I mean, moderate, you use another condition. When you're going to tackle with the budesonide, you're now MMX preparations of your budesonide, and you're going to use that. There is no response even after that kind of treatment, which is going to get initiated even for moderate severity. Sometimes we are getting a patients like that. So there is no strict rules. So based upon the clinical response, ideally to start with your steroids when you're going to consider, start with maximum dosage regimen at least for 2 to 4 weeks of duration, and then you start tapering gradually. every 5 milligrams over a period of 2 to 3 months of duration. That's what the best line of treatment protocol to aid a significant mucus healing as per your various scoring system. And azothioprine ideally to be considered after monitoring your basic levels, and you need to monitor serial counts and your total counts and all those things. And mainly at the rate of once a patient is going to around 5 to 10 milligrams of low dose steroids, it's ideal to add on with the azothioprine at that point of juncture when you're going to maintain a patient, steroid dependent patient. When you're going to maintain a patient for duration of time, at that point you can add azothioprine as a coexisting add-on molecule. But mesalamine is still a different issue. Ideally, mesalamine plus azothioprine alone not to be much of role to be considered. Always steroids with azothioprine is more of role rather than considering with mesalamine and azothioprine.
Mr. Kaur, any more questions?
No, sir.
Okay, no problem. So thank you, Dr. Arun, for your insightful presentation on mesalamine's role in managing inflammatory bowel disease. Your expertise has enriched our understanding, and we appreciate your valuable contribution to our professional knowledge. Looking forward for such more collaborative sessions in future. So thank you for all joining us, and have a wonderful weekend ahead. Thank you.
Thank you very much, and thank you all the participants for being here, and thank you Team Lupin to give me an opportunity to be here, and have a good night. Thank you very much.
Thank you, everyone. Yeah, so now from here, we are closing today's session. Thanks again, everyone.